Okay, well, welcome to the next RadPath lecture on brain pathology. Big disclaimer, I am not a neuroradiologist. This is Matthew Hartman from Pittsburgh, PA. I'm an abdominal imager with a love of RadPath. I am going to count on my residency teaching, stuff I remember from medical school, to try to impart some high-yield facts for you guys. And I hope you enjoy this lecture. Again, the entire lecture can be found on the ACR Building Blocks section. I encourage you to download this, go at it at your own pace, look stuff up. My goal here is to show you some of the highlights, get you primed for the material. And if you like Anki flashcards, download our Anki RadPath deck. You can find instructions on the About section of our YouTube channel. So to think that I can teach you everything about the brain and the neuro radiology in 15 minutes is unrealistic. Again, download the presentation, take a look at it at your own leisure. Oftentimes when we're imaging the brain, especially in the ER setting, acute change in mental status, we'll do a CT scan without contrast. We're looking for intracranial blood, hydrocephalus, real big things that need to be diagnosed quickly. A couple things to be aware of on the non-contrast scan. There are areas where there'll be a lot of what we call streak artifact. This is more of a resident level thing. You'll learn about beam hardening artifact, but this area, the pons, medulla, is notoriously difficult to image because there's a lot of artifact. Note that on the CT, the bone is white. It's the brightest thing there. That's the X-rays are getting absorbed by the bone, as opposed to MRI, where the bone will be hypointense. So that's the first trick if you're a medical student. Try to figure out, is this a CT or MRI? That's the best thing I can say. Look at the bones. Now, once we've decided it's an MRI, try to decide, is it T1 or T2? I think we'll have a nice go back and forth. The best thing I can tell you is the T2, the ventricles will be bright, T2H2O. This works 90% of the time. The exception is if we do a FLAIR sequence, you can see there's the acronym Fluid Attenuation Inversion Recovery. The way to think of this is anything that's 100% water gets negated. So the water in the CSF is now hypointense. A couple of ways that you can identify this as a FLAIR. Again, this is sort of advanced med student beginning resident level material, but I want to throw it out there because there are a couple tricks. I always look at the vents. You see it's a little bit bright around them. That's how I tell it's a FLAIR. And this is great for picking up areas of edema, areas that are not 100% water, but if it's like 80% edema, 80% water, you know, MS cases, lesions with vasogenic cytotoxic edema, it will pick up those areas of inflammation very well. Again, on T1, the vents will be hypointense. Okay. T2 star, this is great for looking for if you're worried about blood products. And artifacts like here with the metal really get accentuated. Call that blooming. DWI. This is a fancy sequence that we use for several things. The most important thing I think at the med student level is to know we use this for picking up acute strokes, cytotoxic edema. That's why we can say we can pick up strokes, you know, within, you know, hours, maybe minutes, whereas the CT, those changes in the gray-white differentiation you might not see for 24 hours. So if you absolutely need to know is there an acute stroke, this is your sequence, restricted diffusion. What exactly does that mean? I think I stole this from somewhere else, but this is the best analogy I found to explain it to med students, is a snow globe analogy. You think of a snow globe with the particles, you shake it up, it moves around. It helps that we have a nice air bubble here that lets more space so the stuff can diffuse around. Now, if you have no air bubble and you shake it up, it's not going to move around as easily. So that's what's happening when you have a stroke. Acutely, you lose the oxygen, you lose the glucose, the sodium, potassium pumps get knocked out. There's no more diffusion of the solutes, the sodium, potassium, starts swelling up, not diffusing, lights up. That's the down and dirty for diffusion weighted imaging. The other way that you can get restricted diffusion is instead of having water in here, if I fill this up with petroleum jelly, something very viscous, and try to shake that up, again, that will not shake up or diffuse. It will all be stuck in there. And with that analogy, think of that thick petroleum jelly stuff. That goes with our other etiologies that have restricted diffusion, including infection, abscess, and tumor. So things that have restricted diffusion: infarct, abscess, tumor, very highly cellular tumors. So those are the basics of the imaging. I hope that helps. Now we are going to talk about identifying and categorizing lesions. And a couple of questions that we can answer will sound like prose. Once we identify a lesion, trying to decide, is it intraaxial versus extraaxial? Is there enhancement? Is there edema? Is there a mass effect? And that will be goes with our pattern of displacement. And then other findings: hemorrhage, hydrocephalus. So this is an MRI. The bones are dark. We have T1 with contrast. So that's a good pearl. Anytime you have with contrast, it's always a T1. And you see in the falx lighting up, some of the vessels. This is T2. The our CSF is going to be bright. And we see the lesion, which is right in the falx. So this will be extraaxial. You can look here for characteristics of extraaxial lesions. The CSF cleft, gray matter buckling. If it's on the falx, the tent, it's going to be extraaxial. And our differential, our friends mesolymphoma show up. Meningiomas love to be on the falx like this, extraaxial. That's actually what this case is. And you can put a couple other rare things, but this is very classic for meningioma. As opposed to this case, again, we have T1 with contrast, the vessels are lighting up, and we have multiple lesions. Multiple, we should be thinking Mets. Lymphoma as well, but Mets are going to be much more common. Abscesses, primary brain neoplasm, it's going to be lower because this is multiple. I'm thinking Mets, and this patient had lung cancer. This is a great differential I want you guys to know. Again, this is T1 with contrast. Vents are dark, and the vessels are lighting up. And then we have a ring-enhancing lesion. So this is without the contrast, and really shows up well when we give the contrast. And this is a great mnemonic, magical doctor. And we'll notice that Mets are on there, lymphoma's on there. So if you only had Mets lymphoma, you got about 1/4 of it. But we also remember abscess, GBM, infarct, contusion, AIDS, demyelinating diseases, and radiation necrosis. But this is a great differential for med students to know in the neuro rotation. Okay, vasogenic and cytotoxic edema. I'm going to pass on this and let you guys read about this. I want to get to some of the real RadPath. This shows some nice displacements. The herniation. This can happen after infarct, like this case. But just realize when we say herniation, mass effect, we're going back to that RadPath pattern of displacement. This is another great differential to know for med students. This is something I remember from my days as a medical student. You get a mass which is crossing the corpus callosum. So this is going to be our FLAIR sequence. This is our T1 with contrast. And again, all this, anything that's 100% water, like the vents, will be hypointense. But if you get edema, it really shows up well on the FLAIR. We see the lesion itself is only that big, but all the mass effect crossing the corpus callosum is that big. So anytime you see a lesion crossing the corpus callosum, GBM, and lymphoma, have to differentiate on imaging. Hemorrhage. If you remember from our intro to imaging, CT would be a great way to pick this up. If we're doing MRI, our sequence is the T2 star, and we'll get that blooming artifact. Also showing up bright and heterogeneous on the FLAIR image. Hopefully we're getting comfortable with some of these sequences. Oh, back to CT. The bones are bright. What do we have here? Well, our vents are dilated. Again, using the Hartman 6 patterns, this is one of our words, dilation. Anytime you have a dilation, is it obstructed? What level is the obstruction? And see if you can think up of a cause for this hydrocephalus. Well, if you notice this hyperdense stuff in the occipital horns, that's hemorrhage. Hey, multiple lesions, think metastases. That's our key, multiple metastases. This is actually mislabeled. This is an MRI T1 with contrast. This is a very complex slide, but the key here is when you get a lesion, it's important to know some information. First, the age of the patient, adult versus peds, and then where is it located, supratentorial or infratentorial. You notice Mets are on a lot of these lists for our adults, not so much for the kids. And this is a great thing about pediatric neuroradiology. You can really have a tight differential if you're able to localize it, characterize it as solid versus cystic, and have a stepwise approach. Okay, so speaking of our stepwise approach, let's go over it. Intraaxial versus extraaxial. Is there enhancement? Is there edema? Is there mass effect? And then looking for the other important findings, hemorrhage, hydrocephalus, herniation. So using this approach, we're going to go through some cases, and we're going to have some good RadPath. So 57-year-old dizziness, left-sided paresthesia, cognitive decline. We can realize this is an MRI. The bones are dark. Things are lighting up, so we think it's T1 with contrast. Here we're seeing some CSF, so T2. And what are the findings? Well, we have a large mass. Looks like it's right there. So extraaxial, right on the temporal lobe. There's some edema around it, which we see on the T2. And this is very similar to our other meningioma. They all look, I shouldn't say they all, but a lot of them will look similar, right on the dura, that dural tail, extraaxial, vividly enhancing. Realize that there's a big gradient, different types of meningiomas, but our classic med student meningioma, remember this one. Okay, case number 2, 51-year-old with vertigo and ataxia. Again, CT or MRI. Well, our bones are dark. This bright stuff, this is actually the fat. Some people will look at that and say, hey, this is CT, the bones are bright. No, this is the fat, which is hyper intense. Our bone is right here, is hypo intense. Our vents are dark. So this is T1. We gave the vessels are lighting up, so it's with contrast. Here, the vents are dark. You're like, maybe it's a T1, but a little bit brighter around it. That's my clue for that's a FLAIR. So with the T1 with contrast, we see a mass which is enhancing, and the FLAIR, we see all this edema around it. So what's our differential here? Well, first of all, intraaxial or extraaxial. And some more imaging. This is our diffusion weighted imaging. It's bright on the diffusion, dark on the ADC. That tells us stuff is packed in tightly, especially if we're thinking of mass. So we're definitely thinking neoplasm now. And this is a CNS lymphoma. Remember, that's the one that can often cross the midline. Not in this one, but if you ever see a mass crossing the midline, think lymphoma or GBM. Okay, case number 3, lung cancer, altered mental status. I know what I'm thinking. What are you guys thinking? We do the MRI. Again, bones are darks. That's an MRI. The vents are bright here, so this is T2. Vents are dark here. This is T1, but our vessels are lighting up, so this is T1 with contrast. Hopefully you guys are getting a sense of how to, I don't pretend to be a neuroradiologist. This is what I did as a med student and resident to get through. Hopefully it's being helpful. But we notice lots of lesions are T2 bright. They're enhancing. Maybe there's some ring enhancement. Definitely some ring enhancement on our T1 with contrast. Remember our magical doctor differential. And hopefully we have a good answer for this, which is METs. And looking for a complication, these vents are too dilated. This is hydrocephalus. So just remember to look for those complications. Okay, case number 4, 44-year-old, altered mental status, left facial droop, weakness. Okay, this is going to be a T1 with contrast. Our vessels are dura. Our falx is lighting up. Our vents are dark. So T1 with contrast. Let's see what we got. This is a tough one. I pointed to the enhancement. If anything, this is too much enhancement. That's the trick here. This is on the meninges, the dura. It's too bright. It's too thick. So again, that's one of our pattern words. Thickening. See what we got here on our T2 and then T1 with contrast. Got some ring enhancing lesions. And then lots of edema on the T2. We get our diffusion, it's bright here, dark on the ADC. So we're thinking something with high cellularity, something very viscous, something where those solutes cannot diffuse. And just remember that snow globe, the snow crystals are not diffusing. Why is that? Well, we talked about stroke, we talked about tumor, and we talked about infection. And that's our a good thing to remember, restricted diffusion. You can also get with infection like abscesses here. So putting this all together, the thickened dura, meningitis, and then with ring enhancing lesions, and then the restricted diffusion with abscess. Okay, a challenge case. And they never heard this before. Don't fall victim to satisfaction of search. Once you make one finding, keep looking. So here's our MRI. Bones are dark. Say the vents are dark. This is a T1, but notice it's a little bit brighter around there. And then we got this area, which is really bright. This is our friend, the FLAIR sequence. It's great for edema. And we're seeing lots of edema there. And then we get some contrast. And we're seeing a couple of things. I'll give you guys a couple of seconds. And you can pause it, you can go back and forth. I'm going to keep going. And say this was a twofer. There was a GBM with a meningioma with our extraaxial Hansen lesion there, and then a more infiltrative, sorry about that, intraaxial mass, and where there was, so there's our meningioma. There's our GBM. So twofer. And went in to resect that. This is from one of my RadPath students. If you ever get a chance to do the neurosurgeries where they do the Neuro Navigator, it's pretty cool. So this was my best job as an abdominal imager to try to teach you some neuroradiology. Remember, there is an approach, just like all our other modalities. And for neuro, it's important, very important to know the anatomy, It's important to know how the study was done, and hopefully that was helpful reviewing the differences with the different sequences for MRI. Again, the T1 with contrast, T2, the FLAIR, and then the diffusion. Identifying the lesion or lesions, trying to decide if it's intraaxial or extraaxial, looking for those ring-enhancing lesions. We've got some great differentials, and then looking for those ancillary findings. Is there hydrocephalus? Is there herniation? Is there hemorrhage?